Okay, this is going to be genetics of dystrophinopathies. We're going to talk about Duchenne's and Beckers muscular dystrophy, as well as myotonic dystrophy. So dystrophinopathies, dystrophin, it gets its name after the word dystrophin. And dystrophin is an incredibly large protein that attaches from actin to the lamin of the cell membrane. And this is important in movement for both skeletal and cardiac muscle. It stabilizes the muscle contraction to the extracellular matrix. When the dystrophin does not stabilize the muscle unit, every time the muscle contracts, it results in damage to the cell membrane. So Duchenne muscular dystrophy, when the dystrophin protein is non-functional, or there's no connection, so there's no dystrophin, there's absolutely no connection between the actin and the membrane, every time the cell contracts, it causes damage to the cell membrane. And this damage results in holes in the cell membrane. Creatine kinase, or CK, is produced and it is a source of energy, and this can migrate out of the cell and be elevated in the bloodstream when there's damage to the cell membrane. So an elevated CK really is a sign of muscle damage. CK, as I said, is important in energy, so depletion in the muscle cell can decrease energy. But the real problem, the real issue when in Duchenne muscular dystrophy is this opening within the cell membrane allows calcium to migrate in. Calcium is usually very closely regulated. And what calcium does is it can activate proteases that destroy the muscle unit. So over time, the muscle cells are taken over by fat cells. To be honest, if I see a baby who's at risk of Duchenne muscular dystrophy, and I do a blood test for creatine kinase, or CK, it could be 20,000 or 30,000, with normal being up to 100. When I see a 6 or 7-year-old, we're going to talk about the clinical symptoms in a second, it might be 6,000, both certainly far excess to normal. But the difference is by 6 or 7, and maybe 20, it might only be 1,000. The reason for that is the muscle has been so destroyed that it's, there's just no muscle left. So let's now look at the clinical characteristics of Duchenne muscular dystrophy. It occurs in about 1 in 5,000 males, and it's inherited in an X-linked fashion, which means the gene for Duchenne is located on the X chromosome. Boys have only one X chromosome, so if the only copy of this gene is abnormal, they will have symptoms. And the symptoms of Duchenne's muscular dystrophy include progressive muscle weakness, calf hypertrophy or enlargement of the calves, toe walking, and lordosis. And this is a photograph of a boy over time and how much lordosis occurs, and that's that incurving at the spine. Patients usually become wheelchair bound by the age of 16, and death typically in the late teens to early 20s because of dilated cardiomyopathy. Again, the heart is the most important muscle in our body, and this problem not only affects the peripheral muscle, it also affects the cardiac muscle. So here's this calf hypertrophy. And the reason it gets hypertrophied is actually the muscle is being taken over by fat. And when we look at the muscle weakness, it's more proximal than distal. And there's something called a Gower sign. And this is just a sign of proximal muscle weakness. When a child is on the floor, he almost has to crawl up to get to a standing position. And here is a video of a little boy who is diagnosed with Duchenne's. And again, he's an active kid, but see how he kind of crawls up his his legs to get to a standing position, and yet he never drops his stickers. But see, kids are very resourceful, but he really has to crawl up. He does it quickly, and as time goes on, he probably won't. But that is a Gower sign. So let's now go to the heart. As I said, the heart is the most important muscle in our body, and patients with Duchenne muscular dystrophy have dilated cardiomyopathy. So cardiomyopathy is defined as enlargement of the heart, and usually it's thickness in the left ventricle. This is called hypertrophic cardiomyopathy. But dilated, the whole heart is big like a balloon, and it's big because of the muscle weakness. And the muscle weakness does not allow the left ventricle to contract the way it should. And when that doesn't happen, the blood isn't flowing correctly. As I said, dilated cardiomyopathy occurs in all patients with Duchenne's muscular dystrophy and Beckers, and it's the most common cause of death. So the muscle weakness is not what kills these individuals, it's the enlargement of the heart. So now we're going to talk about Beckers. Now, one thing before I get started is things used to be named after people, and this is why we've changed the whole name to Dystrophinopathies. Because the difference between Duchenne's, which was defined by Dr. Duchenne, and Beckers, defined by Dr. Becker, is Duchenne's is more severe. But they're both caused by abnormalities in the dystrophin gene. So Becker's muscular dystrophy is really clinically defined as the age of onset. And it also is an abnormality in the dystrophin gene, but the dystrophin is altered but not completely not present. So it's shorter or it's abnormal, and it's usually has a milder phenotype than Duchenne's with a later onset. One of the key differentiating things on a clinical basis between Beckers and Duchenne's is the neck flexors are maintained. Patients are usually wheelchair bound by their late teens to early 20s, and death is between 20 and 40, and again from dilated cardiomyopathy. So it's a little slower of a progression, but the outcome is still poor. As I said earlier, Duchenne's and Beckers, which are both caused by an abnormality in the dystrophin gene, are X-linked. The gene for dystrophin is located on the X chromosome. And up till about 5 years ago, we used to say that females had no symptoms of this. So males only have one copy, and if it's not working, they're in trouble. Females have 2 copies, one that works and one that doesn't. And usually this is random X inactivation. So some cells make the dystrophin normally and some do not. And again, up till maybe even 5 years ago, they said women don't have symptoms of this. They're at a 50% risk of having an affected son, but they're not at risk. We've since realized that's not true. Women with a copy of the dystrophin gene that's not working correctly do show evidence of proximal muscle weakness. It's certainly not as severe as men, but there can be a little bit less random X inactivation that can cause more severe symptoms, but they also are at risk as they get older, not as young as men, but they are at risk of dilated cardiomyopathy. So the dystrophin gene is one of the largest human genes. And this gene consists of 2.4 million base pairs and 79 coding regions or exons. Mutations in the gene can result in protein being produced, mostly nonsense mutations, or an abnormal protein, or, no protein being produced is nonsense, or abnormal protein missense. And about 20 to 35% of patients with an abnormality in the dystrophin gene have a missense mutation. Deletions and duplications of this gene are also very common in about 60 to 85% of patients. And so this is just a representation of the 79 exons. But the interesting thing is exon 51 is one of the most important ones. I'm not sure why, I just know that it is. So management of patients with Duchenne's, physical therapy, again, every time the muscle contracts, you're going to be in trouble, so it's only going to get you so far. Part of this is an inflammatory reaction. So steroid injections have been shown to increase muscle strength and function. Cardiac medications to improve cardiac function and afterload. And research studies exploring future therapy. And I shouldn't even say research studies because a lot of these are now FDA approved. So, management of Duchenne's muscular dystrophy using a molecular technique known as exon skipping. 80% of patients with Duchenne's have a deletion or duplication or mutation involving exon 51. Again, I don't know why, I just know that it is. There's something called a phosphodimerate morpholino oligomer, or PMO, which are charged analogs that bind to the mRNA and hinder splicing of exons between 48 and 52. So remember, you first make a copy of your DNA, and then you transcribe it, and then you translate it. And if you block where you're going to translate it, then you can maybe skip by where there's either a stop codon or a deletion. While the dystrophin is shorter than normal, it will still have some function. Maybe be similar to a Beckers. So here's normal dystrophin. You got all your exons, you splice them together, and then you make your dystrophin. But when we make our RNA and we try to split and we splice them together, if there's a problem at 51, it results in being out of frame and a premature stop codon, and we get no dystrophin. But what if, as we're splicing, while we're still in the nucleus, we add this PMO to block this? So it skips from 48 to 52. So it misses the abnormality on exon 51. And then you get dystrophin. Maybe it's a little bit smaller than it should be, but you still get a protein. And it might be a little, like I said, may turn a Duchenne's to a Beckers, but you'll still have some activity. Now, the caveat to this, though, is that the gene mutation must involve, if you're going to use this particular thing, exon 51. And while that involves a great number of patients with Duchenne's, it doesn't involve all of them. And that's why it's important not just to know the phenotype, but to know the genotype when you're looking at molecular treatments. And again, this is really not experimental. This is standard of care. This is what neurologists do when treating patients with Duchenne's muscular dystrophy. Treating with steroids, physical therapy, is you're treading water uphill. Every time that cell is contracting, you're getting more and more damage. This is actually getting to the problem, which is the lack of dystrophin and the constant inability to control. Every time the muscle it contracts, you have damage to the cell membrane because you don't have dystrophin, which is stabilizing the cell membrane to the muscle. Okay, I now want to move gears to a different disorder known as myotonic dystrophy. And this is another muscular dystrophy, that affects skeletal, cardiac, and smooth muscles. Muscle weakness begins in the face and spreads to the distal limbs. Cardiac arrhythmias is also a very early symptom. And this is a brother and sister. He has like 800 repeats and she has like 500 or 600. But notice how long his face is, how both of their mouths are a little bit open. He's 18 years old. He's already showing signs of frontal balding. So here are some of the clinical characteristics. A long face. They can develop cataracts. Ptosis, so the eyes aren't opening all the way. He has a little bit of ptosis. Inability to release a grip. So when you're shaking their hand, they don't let go, or they have a hard time letting go of a doorknob. Males often show early frontal balding, muscle wasting, and then some can develop gynecomastia. Myotonic dystrophy is a triple repeat disorder, which means there's too many repeats of a certain sequence. And in this case, it's in an exon of the DMP. Excuse me, it's on the 3' end of the DMPK gene. And it's inherited in autosomal dominant. About 1 in 500 individuals have this. And this, this increased number of repeats affects the ability of this gene to be translated. So it doesn't get translated and a protein is not produced. The more the number of repeats on the 5' end of the gene, the more severe the phenotype is. So normally it's less than 50 repeats and the gene gets transcribed and everything's great. But if it's between 50 and 200, there can be a late onset. It usually presents with cataracts and mild muscle weakness, often in the 50s or 60s. Then 200 to 800 late adolescence, the kids that I showed you, and then greater than 1,000 is a baby born with low muscle tone right at birth. So this is something called anticipation, that this can get worse from one generation to the next. And here is a grandmother, a daughter, and the grandson. And the grandmother has early onset cataracts and a little bit of mild muscle weakness. You can see this daughter kind of has this long face, and she very expressionless. And then this baby, you know, is born with severe hypotonia, and you can see his mouth is open. So they have congenital hypotonia, open mouth, and cognitive delays. Individuals with, you know, greater than 300-400 repeats usually have some mild delays, but this is a more significant cognitive delay. One thing I do want to mention about individuals with triple repeat disorders is when we do whole exome sequencing, when we sequence the coding regions of the gene, because in the case of myotonic dystrophy, this is outside the coding region, you're not going to pick it up. When we get to whole genome, which we'll probably be doing routinely in the next 5 years, so I don't even know I'm talking about exome, but then that will be picked up. So here we have late onset, greater than 50, cataracts, some slight muscle weakness between 40 and 100, but once you start getting over 50 repeats, the gene becomes unstable during oogenesis. It can go from 50 to a couple hundred to a couple thousand. Classic, between 12 and 50, and usually between 100 and 1,000 repeats. Childhood, onset between 1 and 12. Again, 500 to 2,000. Usually the 1 to 200 are the milder classic, and when you're getting over 500, I took this from a slide, but I actually think it's when you're 800-900. Those kids I showed you in that first slide had like between 500 and 900 repeats, which learning problems, long face, low muscle tone. And then congenital is over 1,000. Hypotonia, respiratory problem. They can have club feet, which is a sign of low muscle tone prenatally. So this is just an exam question. A 5-year-old is having difficulty rising from the floor. He cannot ride a 2-wheel bike. His mother has a brother who died from complications of Duchenne's muscular dystrophy. What laboratory test would determine the likelihood that he would have the same disorder? And the CK is something you can do in the office. But the actual diagnosis, you need to do molecular testing. And again, it's not going to be close. You know, every lab has different norms. Usually a CK normal is between 50 and 100, and it kind of depends on what their norm is in that lab. So nobody's ever going to give you a lab study without a norm, because every lab's a little bit different. But it's not even close. It's like 1,000, 10,000, you know. And then here's a USMLE type question that I got out of a book. A 12-year-old boy has a particular genetic disease. His mother is a carrier for a mutated gene, but his father is not affected and is not a carrier. The boy has 4 siblings, a sister, a brother who are not affected and not carriers, a sister who is a carrier but not affected, and a brother who is clinically affected, the inheritance pattern is consistent for which of the following disorders? Again, I took this out of a USMLE book, and I put it in this case. So you have an X-linked inheritance, and alpha-1 antitrypsin is recessive, 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 and this is the one that's X-linked. So you could either go with knowing what the inheritance, you know, figuring out that this is X-linked and knowing Duchenne's is X-linked, or knowing, which you just had all the, you know, the PKU, and you already did CF, alpha-1 antitrypsin, knowing no. So 2 ways to do it, but this is the type of exam question. And that concludes this lecture.